Let's change gears a little bit and talk about Merck's vicriviroc, which is their CCR5 receptor antagonist, which is very similar to ViiV Healthcare's Cellentry. And they didn't have a very good showing here in their treatment experienced patients. I'm just wondering if you can comment on what happened there, because I do know that there were a number of patients who actually did very well on the drug. So I'm just wondering what this means, what your take on that is.
That was a very interesting study. I guess in many ways it could be considered what we call a negative study, in that it did not show that the addition of vicriviroc to other combination of drugs that were specifically chosen for a patient called the optimized background regimen, that the addition of the vicriviroc to those best drugs versus the addition of a placebo to those best drugs was any better. It didn't really add any improvement in terms of suppressing virus. And the explanation that they gave for why this was seen was the fact that the background therapy, the drugs that patients now currently have availability to, has gotten to be so good that when that background therapy was analyzed, around over almost 2/3 of the patients had 3 or greater fully active agents in that regimen, so that by adding a fourth, in this case vicriviroc, that no further improvement was seen versus adding the placebo. Now, this is kind of a question, because I think this is something that we have to look at very carefully, because certainly vicriviroc in the phase 2 studies, called the Victor E1 and E2, did show a significant improvement when it was added compared to a placebo. The thing that's, I think, really changed between those studies and these studies is the fact that we now have the wide availability of raltegravir, of darunavir, boosted with ritonavir, and also etrovirine, and as well as maraviroc as well. So we've had 4 agents that have come out in wide use globally now that were not available when this drug was first being developed. So part of this is really sort of the evolution of the background of the antiretroviral available medications that is now making us question whether or not we can get better than, say, 65% proportion of patients being suppressed to less than 50 with a new agent.
Well, as a researcher, do you think that we really need to re-explore how we're studying new drugs that are especially in phase 2 and phase 3 studies? I mean, do you think we're going to be looking at a big change in this?
Well, I think part of the situation is, and that was part of the question and answer after vicriviroc was presented, is that do we really need more new drugs in that patient population? That patient population 5 years ago, triple class experience, highly treatment experienced patients, was the most difficult treat, most in need of new drug population there was. And with the licensure of darunavir in 2006, maraviroc and raltegravir in 2007, and then elvitegravir, and then etrovirine in 2008, that need has been addressed and satisfied in a large way. And it's much more difficult to be able to demonstrate activity in a new drug in that group because it's mixed with so many other drugs. In the treatment-naive group, it's much easier. And what I hear is maybe happening with this drug now is that Merck may choose to, well, I think they have chosen not to continue to develop it in treatment-experienced patients, but shift over to treatment naives again. And from what I hear, there is an ongoing study now that they've already enrolled looking at it as a medication in that group.
But I think going back to your point about the original study in treatment-experienced patients, that there were, even though the majority of those patients had a number of drugs to choose from as a part of their optimized background regimen, there was also a sizable percentage of patients who only had 2 or fewer active drugs to include, and they benefited very much so with the addition of vicriviroc. So it does seem like there really is still a need for new drugs for treatment-experienced patients.
I think that's true. It kind of depends upon kind of how treatment-experienced patients are. In my own practice and what I've seen in many of these clinical trials, it's getting increasingly difficult to find what we used to call the triple class or triple resistant class patient population. While there are still patients like that around, it's very hard to be able to enroll them into studies now because they're just not as frequently found as they were before. But I think, even though we don't need this drug for a lot of people, there is going to be a need for, I think, a smaller group of people who still need well-tolerated, easy-to-take, combinable medications, because not everyone's going to respond to all the drugs all the time. The other thing I just want to highlight about vicriviroc is the fact that at the end of the presentation, we heard something that may or may not be a little concerning, and that was although there was a question from the audience about deaths in this study, and what we heard sort of after the fact of the presentation was that there were 7 deaths with the vicriviroc study versus 0 deaths in the placebo study. The explanation for why this occurred so in an imbalanced way is yet still to be fully understood, but I think it's something we may want to kind of look at carefully as well.
Absolutely, absolutely. And we'll switch gears one more time, just talking about another CCR5 receptor antagonist from Tobira Therapeutics, and they had a very small study, 10 days in length, that showed that the drug really does have a profound effect on viral load. The interesting thing about that is they also talked about that drug actually blocking another receptor called CCR2, which they say has anti-inflammatory properties. And I'm wondering if you could comment a little bit on that.
Well, I think there were actually 3 very interesting things about the Tobira compound. One was the fact that it's once-a-day compound without boosting, unlike Retroviruses, which is currently twice a day, unlike vicriviroc, which requires ritonavir or some other booster boosting to make it once a day. This drug does not have to be given with any kind of booster and still given once a day, so that's an improvement right there. Number 2, its metabolism is different than either Retroviruses or vicriviroc, meaning that it is not going to have the drug-to-drug interactions through the liver metabolism that those drugs had. And number 3, it has this, what may be a very unique and interesting sort of new CCR2 blocking activity as well. CCR2 is one of those proteins on the outside of a T cell, which is a way that the immune system tells the T cell to start reacting. And what has become very clear in even well-treated HIV infection is that chronic immune activation or inflammation continues to be a big problem and may be part of the reason that heart disease, brain disease, liver, kidney disease may continue to be a problem even in persons who have been suppressed on HIV therapy for a long period of time. Anti-inflammatories have been suggested as a way to try to treat this, and blockade of CCR2 may be a good way to do this. So this may be sort of a 2 mechanism by 1 drug sort of deal where they could both block HIV infection by blocking CCR5, but also block inflammation with blocking the CCR2 molecule as well.
And I know ViiV Healthcare's Cellentry, they're also looking at potential anti-inflammatory properties there. Dr. Hardy, thank you very much for joining us. I appreciate it, and I hope you have a good rest of the conference.
Thanks very much.